I took a little liberty here and changed the title to Current Treatments in Development for NASH. And what I would like to do this morning is talk to you about some of the new drugs and other approaches that are being used for the treatment of NASH. So here are my conflicts of interest. And also thank Patrick for giving me this opportunity to come back again to this really fantastic meeting. So these are the first prospective data on clinical outcomes in patients with NASH. So in about 2,000 patients, prospectively followed in a protocol-mandated way, adjudicated outcomes. We presented the actual outcomes in these patients. And what you see is that for stage 0 to 2, there are virtually no liver-related outcomes within a median follow-up of about 5 years and maximum follow-up of about 10 years. When you get to stage 3, you start seeing some outcomes over here, but principally, most of these outcomes occur in the cirrhotic patient. And you see over here that encephalopathy and increase in MELT are two of the most common decompensating features in NASH. A little bit different than hepatitis C, where ascites is the most common decompensating feature. Furthermore, we see that as your fibrosis progresses, your risk of extrahepatic outcomes increase as well. So there is a collinear progression of both the liver disease and the extrahepatic disease, so that by the time you get to cirrhosis, you can see over here cerebrovascular disease is highly represented. Interestingly, cardiovascular disease is relatively flat. Now, when you go to hypertension, cirrhosis is a disease that historically we always say is associated with vasodilation, low blood pressure, but look at this. These are prospective data. The new incidence of hypertension is highest in people with cirrhosis, and it progresses progressively with fibrosis stage. And development of CKD and a decline in eGFR is also highly significant as you progress with your liver disease. So what all of this is telling you is that there is multiple things going on. Unlike hepatitis C, which is primarily a liver disease, when we start talking about NASH, it is part of a multisystem disorder, and mortality and liver-related events almost invariably occur in the context of advanced fibrosis and cirrhosis. And the incidence of extrahepatic outcomes increase with progression from mild to moderate to bridging and then cirrhosis. And patients with lower stages of fibrosis is primarily a systemic cardiometabolic disease in terms of outcomes. All right, so this gives us this concept of multisystem disorder. And as liver doctors, we're, of course, focused on the central element, which is the liver disease. But all our patients also have diastolic dysfunction, they have atherosclerosis, they have pancreatic stress, and they are set up for chronic kidney disease. Now, Anna Carolina beautifully showed you many of the tools that we currently have to improve these different end organ diseases and how some of them could actually be used in the context of NASH as well. The one thing that cuts across common across all these different end organs is weight loss. Of course, we use the word loosely. When you say weight loss, it's very important to make sure you're losing adipose tissue and not muscle mass. So it's very, very important to be sure what you mean by that term. We've learned recently that while bariatrics is very good, there are subsets of people who have persistent. So half the people who have advanced fibrosis continue to have advanced fibrosis, and so it does not help everybody. The other very concerning story that is emerging from a lot of studies, look at the number of studies over here, is very consistent data that the suicide risk is increased after bariatric surgery. So it is not a magic solution. You have to very carefully select your patients, and a part of that selection process is behavioral assessment. Also, addiction risk, particularly alcohol, increases substantially after bariatric surgery. And so again, all of these things need to be addressed in your pre-surgical assessment process. And then there are subsets of patients with cirrhosis who can actually decompensate if you undergo bariatric surgery. So we need better approaches to weight loss. So one of the great things that we have learned over the last 10 years is the neurocircuitry of addiction. And this addiction, whether it is food, gambling, sex, alcohol, cocaine, the circuitry is exactly the same. And once this circuitry is turned on, the body defends this circuitry very robustly. So if you take away the ability to eat, people will switch to other types of addiction behavior. But knowing this neurocircuitry also gives us the current paradigm of behavior where essentially you have withdrawal, preoccupation, binge eating, and it goes in cycles. But we know what are the essential drivers in this, and serotonin appears to be an important player in this role. So this is recent data from the New England Journal showing a serotonin 5-HT3 antagonist, lorcaserin, which shows significant weight loss. It is now approved for weight loss, but it didn't really impact cardiovascular outcomes. So you could argue, why use it? But anyways, it does produce weight loss, currently being studied for NASH. Then there are other approaches about mindfulness and simple tools which don't carry much side effect profile. And this is a very nice analysis, meta-analysis of multiple studies looking at mental and physical health parameters in people with metabolic syndrome, showing that you can cut the outcomes by about half almost by doing simple mindfulness-based stress reduction approach and being able to successfully engage in these. So you may not need to obviously take toxic drugs in everybody. Another new molecule that we are actually very much involved in is this Gilead 100. And these are little microcapsules that when you ingest it right before a meal, as soon as they come in contact with gastric acid, they swell up. So imagine like a Linton tube, the balloon, your stomach suddenly fills up with this foam, so your stomach is full. You don't feel like you need to eat anymore, so you reduce how much you eat. These are the data from the pivotal trial. This has recently been approved for obesity, and it also has a moderate benefit on obesity. And you can see that this is all quite significant over here. So this is currently under study for the treatment of NASH. Data will come out in a year or two. Another very interesting approach that we're involved in is duodenal mucosal resurfacing. So what you do over here is what we put a scope in, then we put a catheter and lift the mucosa by injecting saline. And then we induce a hydrothermal burn for over a 10 centimeter circumference of the duodenum in the second part onwards. And essentially that mucosa sloughs off and then resurfaces. And what that does, the concept of this comes from bariatrics, where when we exclude the duodenum from the food path, we see improvement in metabolic parameters even before weight loss occurs. So that led to the idea that if you ablate the duodenal mucosa, you might get the same benefits. So this is a phase 2 trial that we just presented at ASLD just a few weeks ago, and 60% of the patients showed 30% defatting of the liver. And this is not, when you pair match them for the amount of caloric intake, that did not really change. And very interesting, on top of background therapy, A1C dropped by 0.8 compared to 0.3 in the sham-operated patients. And the hemoglobin A1C data, we now have data up to 1 year that actually there is a difference that is sustained even a year out. Very interesting. Advanced phase trials are starting up. There are also studies now being done with gastric balloons. This is a very early study with a 6-month study presented by the Mayo Clinic group showing improvement in the NAS score. This is the sham-operated group. And once again, I think there are a lot of new approaches being brought to actually get effective weight loss. Now, when it comes to drug therapy, you need to, one of the key principles is that the drug must affect a target that is relevant. So the disease starts with a metabolic substrate overload of the liver that causes cell stress and apoptosis, which then drives an inflammatory response. Prolonged inflammation leads to fibrosis, eventually culminating in cirrhosis, which is linked to clinical outcomes. So there are targets at each of these points, and there are over 30 targets or 40 targets currently in play. So without going through all of those, I'm trying to lump them into buckets so that we can get a broad idea of where the field is going. Now, we already talked about NASH as a multisystem disorder. Now, the second concept I want to bring forward is the concept of competing risks. Competing risks means our patient not only is at risk of progressing to liver cirrhosis and dying of liver disease, but simultaneously is at risk of dying from heart disease and cancer and CKD, et cetera. So imagine there are 4 people trying to shoot at you, and you only put up a shield and protect from one, but the other 3 still get you. The net outcome is still going to be the same. So if you want to really change the outcome of your patient, stop thinking like a hepatologist, start thinking like a doctor. Okay? So you have to improve all of the above in these patients if you're going to improve the outcome. So the goal of therapy is not only in the short term to improve NASH activity and fibrosis, but in the long term to improve outcomes. And there our drugs or approaches must improve cardiovascular risk profile, glycemic control, development of hypertension and strokes, development of CKD, and of course, liver outcomes. So if you use these scorecard, let's look at these broad classes of drugs that are currently in play. So we have insulin sensitizers over here, which cause weight gain. A lot of people don't talk about this. We talk about like pioglitazone is great, vitamin E is bad, yet pioglitazone causes an increase in LDL cholesterol. Nobody seems to be bothered by it. But that somehow reflects, I think, lack of awareness within the physician community, in my view. It's neutral on MACE, and we don't know if it stabilizes GFR. And glycemic control, of course, is improved, and it does have benefits on NASH. Then is the bile acid axis, and we'll talk more about this in detail. FGF21, which actually causes weight loss, but it has a pretty good profile with lipids. Glycemic control is neutral. We don't have data with FGF21 on MACE and GFR. We don't have histology on data on NASH. Thyroxine beta receptors, again, very good lipid profile. They're fairly neutral on weight. In fact, if they had weight loss, you would wonder whether they truly are thyroid beta receptor agonists. And then it does improve activity, but fibrosis improvement is modest. And then we'd heard about GLP-1s already. So let me quickly review for you the phase 3 trials, and I'll show you the ones for which the data are already present. I can tell you that RESOLVE-IT data with Genfit's elafibranor is coming. We will hear it later this year, and so is Senecriviroc, which is further along in development. There are several other with Madrigal and Viking's thyroxine beta receptor, which are in startup. Galmed's drug is in startup, and FGF19 is in startup. So this is the REGENERATE trial, which is completed now, 3-arm study, 2 primary endpoints, co-primary. Either one would be considered a success for the short-term surrogate approval by FDA and the European agencies. And essentially, this is what it shows. Increase in stepwise improvement in fibrosis in the ITT population, which is stage 2 and 3. And in the expanded ITT, which is stage 1, 2, and 3, you see the numbers are somewhat higher, indicating that the disease is more malleable in its earlier stages. But very consistent with what we published in the Flint trial several years ago. Now, you may say this is very, very modest. But when you come to NASH, you cannot think like hepatitis C. Well, we'd love to think like hepatitis C, where we have 99% cure. But NASH, we have to think like diabetes. If you remember with GLP-1, which Anna Carolina showed is a game changer in the diabetes field, the absolute difference between the control and the treated arm was just under 2%. Okay? So, but when you have millions and millions and millions of people involved, 10% difference is a lot of lives. So remember that. So it also improves NASH activity. And these are data, again, from the Regenerate trial. This will be reviewed by FDA in April. Now, one of the big problems with FXRs is you stop cholesterol from going into bile acids, so the cholesterol levels go up. Now, this is important, and this is an important concept for anyone taking care of NASH. Normally, when your triglycerides are low, your VLDL particles that your liver makes, which are triglyceride particles, are small. Lipoprotein lipase in the periphery gets rid of the triglyceride, leaving behind an intermediate density lipoprotein, which is enriched in cholesterol, and that leads to LDL, okay? Now, when you have NASH, your liver's making a lot of triglyceride. So this VLDL particle is very big, full of triglyceride. When it is circulating, the triglyceride, the lipoprotein lipase is unable to hydrolyze and get rid of all the triglyceride. So your intermediate density lipoproteins are big and contain more triglyceride than they should. This makes it susceptible to hepatic lipases, which take your LDL particles and cleave them. So for the same amount of cholesterol, you have more particles, smaller particles, which are more atherogenic because they can penetrate the vascular wall more easily, and there's more surface area, so they get oxidized and become more pro-inflammatory. So when you use OCA, what happens is that your VLDL particle, the large VLDL particles, which are bad, go down. So while the LDL goes up, the bad VLDL goes down, and your large LDL particles, the small dense LDL particles over here go up slightly, but there's a big increase here in the LDL particles. Now, TropFX is a small molecule, also binds to FXR, different than OCA, which is a bile acid derivative. But here it shows from the flight FXR trial that very nice improvement in ALT, similar improvement in hepatic steatosis. Histology data is yet to come. It will come probably by the end of the year. But if you hit the FXR hard enough, LDL goes up here also, but is manageable with statins. Now, Metacrin has a FXR agonist, and they showed very early data, and what they showed is that there was no change in LDL. Now, I think we need more data. This is a very small study, and I think if you hit FXR hard enough, it's a class effect. I'd be surprised if you don't see that in future studies. Now, going to phase 2 and drugs in early development, once again, there are a lot of insulin sensitizers in play, and there are a lot of drugs targeting the de novo lipogenesis pathway. There are new studies directly targeting PNPLA3 with a silencing approach and DGAT2 inhibitors. There's no data yet to talk about, so I'll focus on the few things where there are data. So starting first over here, so we have also the PPAR alphas. We mentioned PPAR alpha delta already. The Resolve It trial data will come out. And then let me first show you the mTOR data. Then I'll show you some data with PPAR alpha gammas and then ACCs. So this is data with MSDC. This is a mitochondrial target of thiazolidinediones. Turns out pioglitazone not only works through PPAR gamma, but it also has some effects through these channels. So there was a concept that maybe you can get the benefits of pioglitazone by just targeting the mitochondrial channels and pyruvate channels. And what you see is you get a modest improvement in activity, but you really don't have too much of a signal over here. So relatively modest, especially in the competitive landscape, not a big signature for NASH improvement per se, although the systemic milieu of insulin resistance and dyslipidemia got better. Now, this is a very interesting molecule, saroglitazar. It is a PPAR alpha gamma. For historical reasons, alpha gammas were considered to be bad molecules, but this molecule has been studied extensively in India and is approved there for diabetic dyslipidemia. Over 250,000 patients have received this drug with no safety issues. So here is an early phase study done in the US and Mexico, and it shows fairly significant defatting of the liver. reduction here again, fat content over here. This is the percentage of patients. Almost 60% of the patients have this fat, more than 10% fat reduction, and about 40% have more than 30% fat reduction, and with a stepwise decrease in the ELF score. So I think histological trials with histology will read out later this year, and this is going to be an important molecule to keep an eye on because the overall metabolic and extrahepatic profile looks really good. Here are data with the acyl-CoA carboxylase inhibitor from Pfizer. Very potent defatting. Remember with saroglitazar, 40% people had more than 30% fat reduction. Here there's 90% at this high dose. 90% of the patients had similar range of fat reduction. But it increased triglycerides and increased alkaline phosphatase, increased GGT. So I think in this disease, the safety bar is very high. So I think future studies will have to identify a small therapeutic window. We have to see how that works out. In another ACC study, it also showed high triglycerides, and this is the Gilead molecule, but they showed that with fenofibrate, you can control this process. SGLT2 inhibitors have been shown to improve renal function and cardiovascular outcomes and all-cause mortality in type 2 diabetes with high-risk cardiovascular features. This is licogliflozin is a SGLT2 1 and 2, so into blocking in the gut and in the kidney. And this is from Novartis, and they show very nicely over here the weight loss. Then you see an improvement in ALT and GGT. I think very early studies, early in development, but I think there's a trial with this and TropFX are already in the works. And so it'll be very interesting to see how that combination works out. You already saw that GLP agonists can produce significant, almost bariatric range weight loss. I think the semaglutide trial will read out in April or May of this year. Good study with 400 patients. This should be a very important study to look out for. So I will finish by saying that, NASH is part of a multisystem disease. When you make the initial diagnosis, unless in the pre-cirrhotic state, there is no urgency to jump to doing things just because you can. You have time, outcome rates are low. At that point, you start with weight loss, consider optimizing the cardiometabolic and renal risk profile, statins, fibrates, saroglitazar may or may not be relevant depending on what it is. Use of GLP-1, SGLT2s are already going to become first line, particularly if you already have type 2 diabetes. Now, because many of these may have benefits on NASH, there's no reason to add additional therapies. You continue to follow the patient and reassess at some point. Those who have residual active disease with significant fibrosis, then you bring in targeted therapy for NASH. Particularly, I think the F3 is going to be the sweet spot for pharmacological treatment because there you start seeing outcomes. You can make a difference within 5 years in terms of patient outcomes and where the disease still can be modified. F4 has been very difficult to move. Pretty much all the trials in F4 have failed in my view to date. So, and then of course you reassess as you go along. I thank you for your attention.